In this video, I'm going to be talking about the pharmacology of vasoconstrictors and the effects of vasoconstrictors on the different receptors. In general, local anesthetics are vasodilators. We add epinephrine and levendorphin to constrict blood vessels in the area. Vasoconstrictors are drugs that constrict blood vessels, and vasoconstrictors stimulate the action of the sympathetic nervous system, specifically alpha and beta receptors. Norepinephrine predominantly affects alpha receptors. Alpha receptors contract smooth muscle of blood vessels. Epinephrine predominantly affects beta receptors. So beta receptors are responsible, they're cardiac stimulators and they're bronchodilators. Beta receptors have potentially adverse cardiac effects on rate and force of contraction. So we have to keep that in mind when we're giving epinephrine, that they can have adverse cardiac effects by increasing the rate and force of the contraction of the heart muscle. Reasons that we would give vasoconstrictor or add vasoconstrictor to local anesthetic are to decrease blood flow to the injection site, to slow the absorption of local anesthetic into the cardiovascular system. We keep it in that area longer because it's constricted the blood vessels in that area. So this allows for slower absorption and lower blood levels. It allows for increased volume of local anesthetic to remain in the area, so you have a longer duration of action of the anesthetic. And it also decreases bleeding and helps with hemostasis. The best injection technique for hemostasis is an infiltration technique. A supraperiosteal infiltration, remember we talked about those being used a little bit interchangeably. So a supraperiosteal injection would be a single tooth injection, usually maxillary at the height of the mucobuccal fold, 3 to 5 millimeters, with our deposition site at the apex of that tooth. Infiltration, localized infiltration, is usually deposited closer to the site where the small nerve endings are. So maybe even in the papilla of the area when we've just got a couple of, tiny nerve fibers that are still allowing the patient to have some feeling or some pain sensation. Now, epinephrine and norepinephrine are naturally occurring vasoconstrictors. Levendorphin is a synthetic vasoconstrictor. Now, 1 to 1,000 means 1 gram per 1,000 milliliters of solution. 1 to 100,000 means 1 gram or 1 drop per 100,000 milliliters of solution. Which is more dilute? Well, of course we know that the 1 to 100,000, because it's 1 drop to 100,000 versus 1 to 1,000. 1 to 100,000 is typically our 2% lidocaine, which is the most common anesthetic injection. 1 to 20,000 is a common dilution for levendorphin. Levendorphin is a synthetic vasoconstrictor. It is typically just found in 2% mepivacaine at a 1 to 20,000 ratio. It's a synthetic vasoconstrictor and it's 1/6 as potent as epinephrine, but it is manufactured in a higher concentration, the 1 to 20,000, to achieve the same effect as the 1 to 100,000. So the 1 to 100,000 common dilution for lidocaine with epinephrine and the 1 to 20,000 common dilution for mepivacaine with levendorphin are equally as potent because of the concentration. Levendorphin is 1/6 as potent, so it is in a higher concentration. Epinephrine is also known as adrenaline. It's an acid, salt, and water, and it will decrease the pH of an anesthetic. It deteriorates quickly, and that's prevented by adding sodium bisulfite as a preservative. The shelf life of an anesthetic solution with epinephrine is shorter than without, and there's also a nitrogen bubble in the cartridge to prevent oxidation. Now, remember we said that sodium bisulfite is a preservative that people can be allergic to. So if someone is allergic to dried fruits, wine, which we'll see in a future slide, then they could have an allergy to the sodium bisulfite preservative, which is in a local anesthetic that contains epinephrine. Epinephrine in the anesthetic will warrant a shelf life, or the shelf life will be 18 to 24 months. Without epinephrine, a regular local anesthetic can be good for about 48 months. So epinephrine really shortens the shelf life of an anesthetic. Sodium bisulfite is a preservative. Sodium hydroxide is a buffer that adjusts the pH of the solution. Sodium chloride creates an isotonic solution that's more compatible with the tissues. So make sure you know the difference between the sodium bisulfite as the preservative, sodium hydroxide. I think hydroxide, the H in hydroxide and the pH, and then sodium chloride, I think the isotonic with the S and the C, sodium chloride. Sodium bisulfite is added to cartridges to preserve epinephrine. So patients with sulfite allergies should not receive local anesthetics with epinephrine. In particular, they shouldn't receive articaine because articaine is always manufactured with epinephrine. The actions of epinephrine are that it increases blood pressure, increases heart rate, increases cardiac output, which altogether decreases cardiac efficiency. We wouldn't want to use vasoconstrictor with patients who've had a recent heart attack or stroke, coronary bypass, who have uncontrolled hyperthyroidism, angina, or arrhythmia. In the skin, epinephrine produces vasoconstriction of vessels in the skin and mucous membranes. In the respiratory system, epinephrine dilates smooth muscles of the bronchioles. In the CNS, epinephrine has very little effect, and it could cause an elevation in blood sugar, but you need at least 4 cartridges of 1 to 100,000 lidocaine with epinephrine for there to be any change in the blood sugar. Usually, if there's going to be any type of epinephrine reaction, it's going to happen within 1 minute. Any adverse reaction with epinephrine lasts about 5 to 10 minutes. Levendorphin is 1/6 as potent as epinephrine, so it's not as effective as a vasoconstrictor. It does produce less cardiac stimulation, so that would be a reason to use levendorphin, and levendorphin is only available in the mepivacaine in a 1 to 20,000 dilution. It is recommended to use a vasoconstrictor whenever possible. When a patient experiences pain, they release their own endogenous epinephrine in response to that pain. That's not ideal because we can't control how much epinephrine is being released by their body, but we can control how much we're giving to them. The maximum recommended dosage of epinephrine that we will give a healthy patient is 0.2 milligrams, and a compromised patient will get the cardiac dose of 0.04 milligrams. The healthy dose, 0.2 milligrams, we would divide by 0.018, which is the amount of epinephrine in one 20 milliliter cartridge of 1 to 100,000 epinephrine. That equals 11 potential cartridges for the patient. For the cardiac dose, we would divide 0.04 by 0.018, which is the epinephrine amount in one cartridge of 20 milliliters, 2% lidocaine, and that equals 2.2 cartridges. When we're determining dosages, we take the amount of epinephrine in a cartridge of local anesthetic, and if the dilution is 1 to 100,000, one cartridge contains 1.8 milliliters of solution. So we divide that and we get the 0.018 milligrams of epinephrine per 1.8 milliliter cartridge. And then, like in the previous slide, I was saying we divide the healthy 0.2 divided by 0.018 to get 11 cartridges, or the cardiac dose of 0.04 divided by 0.018 to get the 2.2 cartridges. If a patient is compromised and the dosage is limited to 0.04 milligrams of epinephrine, how many cartridges of 1 to 100,000 epinephrine anesthetic can I use? 0.018 per cartridge. 0.04 divided by 0.018 gives us 2.2 cartridge. We can do the math or we can memorize this. Can you think of an easier way? Some cartridges say a minimum of 1.7 milliliters. If this is the case, then epinephrine calculation is a little bit different. 0.017 in one cartridge, 0.034 epinephrine in 2 cartridges, and 0.051 in 3 cartridges. So how many cartridges can a medically compromised patient have? The answer is still 2. Local anesthetic and vasoconstrictors must be calculated separately, and the lower of those 2 doses is the maximum recommended dose of the combination. This is called the limiting factor. So there is going to be a limiting factor. It's going to either be the epinephrine. In the case of a cardiac patient, it's always going to be 2 cartridges, or we're going to figure it out by the patient weight, the drug percentage that we're using. Is it 2% lidocaine? Is it 3% mepivacaine? Is it 4% prilocaine? 4% articaine? So the drug percentage concentration, the amount of local anesthetic in the cartridge, 1.7 or 1.8, the maximum recommended dose for the specific anesthesia, and we're going to look at the milligrams per pound, and then the medical information. If it's a cardiac patient, if it's somebody who needs a cardiac dose because of their medical condition, then it's always going to be the 0.04 divided by 0.018, or 2 cartridges, 2.2 cartridges. There are some specific agents that we use in local anesthetic, and we need to know these because when we do calculations, we need to know that it's 2% lidocaine or 3% mepivacaine. Factors that can affect anesthesia and that we have to consider when we're deciding on what anesthesia we're going to use is the individual response to a drug, how accurate we are in our administration, the status of the tissues, is there any infection present, do we have a lower pH situation, is there any anatomical variation with the placement of the injection, and what type of injection it is, and how to choose an anesthetic. Procaine is Novocaine. It was the first local anesthetic. That's why we talk about it. It's an ester. It's no longer used. There were significant allergies. Allergies were to the metabolism and the byproduct PABA. It was the most vasoactive, but it had a slow onset. Stopped in the 50s. So when people say they're allergic to Novocaine, they're really not. I'm not going to argue with them, but it hasn't been around since the 50s, and we don't use it in dentistry in the United States. We've got lidocaine or xylocaine. This is an amide, so amides are metabolized in the liver. The ester that we just saw is metabolized in the plasma by the enzyme pseudocholinesterase. The amides, which is now the drug of choice, are metabolized in the liver. This is available in a 2% concentration with or without vasoconstrictor. We've got our 1 to 50,000, 1 to 100,000, and 1 to 200,000 ratios. It's fast acting. With lidocaine, the 1 to 50,000 is a higher concentration, and we're never going to inject that. We may give an infiltration, like if we need some hemostasis in the tissue where there's just some bleeding that we need to control, but we're not going to give a PSA or an MSA or an IA of 1 to 50,000, never. 1 to 100,000 is going to be our most common. And then, of course, we talked about 1 to 1,000 being our epinephrine, our emergency dose. Mepivacaine is an amide. It's there's less vasodilation than lidocaine, so it stays in the area because it doesn't dilate the capillaries in the area. It's available as a 2% with vasoconstrictor, which is our levendorphin, and in a 3% concentration without vasoconstrictor. It's recommended for short dental procedures where a vasoconstrictor is not indicated. We're typically going to use mepivacaine 3% on children or elderly. Lidocaine and mepivacaine are xylidine derivatives. They have pretty equal potency. They have anticonvulsant properties. They're kind of intermediate acting with vasoconstrictors, short acting without. Lidocaine has a half-life of 1.6 hours, and mepivacaine, which is carbocaine, has a half-life of 1.9. And here's mepivacaine or carbocaine, so 3%. Prilocaine. Prilocaine is an amide. Concentration is 4% with epinephrine 1 to 200,000. This is metabolized in the liver and the lungs. Now remember, Orchix contains 5% solution of 2.5% lidocaine and 2.5% prilocaine. It's contraindicated with a history of methemoglobinemia and respiratory disease with hypoxia. Mepivacaine and prilocaine have the least vasodilating effects and are effective with no epinephrine. And it's a toluidine derivative, so it's the least toxic anesthetic available. It's got a half-life of 1.6 hours. And that's prilocaine. Prilocaine is citinist and it comes in a 4% solution. Articaine is an anesthetic that we don't want to use on people with a sulfite allergy. Sulfites are in any anesthetic that contains a vasoconstrictor or epinephrine. Articaine is not available without epinephrine. So anybody with a sulfite allergy, we're going to use mepivacaine without epinephrine. We're going to use something else but not articaine. Salad bars and certain other foods can also contain sulfites, dried fruits, and people who have sensitivities or allergies to those, we would not want to use articaine or an epinephrine containing anesthetic. So articaine is an amide. It is an amide that behaves like an ester. It's a concentration of 4% with epinephrine 1 to 100,000 and 1 to 200,000, slightly slower onset of action than lidocaine. It's contraindicated in patients that have a history of methemoglobinemia, and it's contraindicated for those who have a sulfite allergy. There's not many times that we do a mandibular infiltration because it doesn't work well due to the dense bone. If it is done, articaine is the anesthetic that's going to work best to get through that more dense bone. Bupivacaine is our Marcaine, or our longer acting anesthetic. It's an amide with a concentration of 0.5%. It's a long duration. It may be contraindicated in children and geriatric patients because it stays in their system longer, and if it's in the system longer, there's more potential for toxicity. It's a thiopine derivative. It's got a thiopine ring, which gives the local anesthetic molecule better diffusion properties than lidocaine. Got a half-life of 3.5 hours. Bupivacaine or Marcaine, 0.5%. Then we've got atidocaine, and it always cracks me up that this is a slide that we still have on here, but it's an amide, long duration, may not be suitable for children, and it's no longer used in dental settings, but we'll see this used as a distractor with multiple choice questions, so that's why I keep it in here. So maximum recommended doses for local anesthetics are based on a 150-pound healthy adult. The dosages are based upon a person's body weight, and we always use the minimum amount to achieve the desired effect. We're going to calculate the maximum recommended doses for local anesthetics by knowing that 2% lidocaine means there's 2 grams per 100 milliliters that equals 20 milligrams per milliliter. So one cartridge containing 1.8 milliliters of solution of a 20 milligram per milliliter solution contains 36 milligrams of local anesthetic drug per cartridge. So if we've got 2% lidocaine, that's 20 milligrams per milliliter. If we've got 3% mepivacaine, that's 30 milligrams per milliliter. If we've got 4% articaine, that's 40 milligrams per milliliter. Then we times it by the 1.8 or the 1.7 milliliters in a cartridge. So 2% lidocaine, 20 times 1.8 is 36. 3% mepivacaine, 30 times 1.8 is 54. 4% prilocaine or articaine, 40 times 1.8 is 72. If it's 1.7 milliliters, then it's times 1.7. So instead of 36, it's 34. For the 3% mepivacaine, instead of 54, it's 51. For the 4% articaine, instead of 72, it's 68. The maximum recommended doses for local anesthetic have recently changed. I have put a new updated chart in your workbook, so we'll be using that. The maximum recommended dosages for local anesthetic for 2% lidocaine used to be 2 milligrams per pound. So you may see in old reading or old information 2 milligrams per pound. The new calculation is 3.2 milligrams per pound, still with a 500 milligram absolute maximum. Now, this changes the calculation on the following slide. So how much 2% lidocaine can a 110-pound patient safely be given? If it's 110 pounds times 3.2 milligrams per pound, that gives us 352 milligrams. Each cartridge of lidocaine still contains 36 milligrams in a 1.8 milliliter cartridge. So instead of the 220 there, it's the 352 that we got by multiplying 110 times 3.2. So 352 divided by 36 milligrams of lidocaine in a 1.8 milliliter cartridge gives us 9.7 cartridges of 2% lidocaine that can be given to the patient based on the new updated chart. So instead of 6, it's 9.7 cartridges of 2% lidocaine. Remember that we talked about the limiting factor either being the epinephrine or the lidocaine based on weight, the actual lidocaine drug based on weight. So the maximum dosage that could be given to the patient based on epinephrine for a healthy patient is the 0.2 divided by 0.018 of epinephrine in a 1.8 milliliter cartridge. And that's a calculation for you to memorize, which equals 11 cartridges for a healthy patient. 11 cartridges is what we could give the person, or 9.7, whichever is less. And in this case, the limiting factor is the lidocaine, so we would only be able to give 9.7 cartridges total, which is still plenty of anesthetic for most of the things that we might do. Local anesthetics are not considered teratogens. They do cross the placental barrier, and some are safer than others. We want to try to avoid elective treatment during the first trimester, but we can use dental anesthetic safely on pregnant patients. We have lidocaine as a class B, mepivacaine as a class C. So we would typically use lidocaine. Epinephrine is considered class C, so we wouldn't use epinephrine.